Good afternoon and welcome to the MS Focus Ask the MS Expert. We have Dr. Boster with us today on this glorious summer day. He and I were just comparing notes about the temperatures where we live, and on the southeast coast of Rhode Island, it's gorgeous with low humidity in mid 70s, and I guess it's similar in Ohio, right?
It certainly is. It's absolutely beautiful outside.
Well, I wish the same for as many of you as can possibly have that. Um, I normally dread summer because of the heat, but anyway, let's get on with this. My name is Sherry Binns. I'm the patient healthcare liaison for the Multiple Sclerosis Foundation, and I have today with me Dr. Erin Boster from the Boster MS Center. And I'd like to just give some instructions on the questions that you're going to ask Dr. Boster today. If you would not mind, please steering clear of the chat. We want to leave the chat free for those that are watching us live on Facebook. And our behind the scenes tech person, Bhavya, is going to be putting their questions into the chat. So if you want to ask a question of Dr. Boster, put it in the Q&A. And if you want to ask him the question yourself, raise your hand virtually. It's under the reactions. If you're on Zoom, at the bottom center of your screen, there'll be a raise hand button. You can do that. I will acknowledge you when we have the ability to do that and let you unmute and ask your question. Okay, I see we have, let's see, we've got a couple of questions already in the box. Tiffany wants to know, what is your opinion on ivermectin for MS treatment?
Ivermectin has not been studied for MS. I do not recommend it for MS. I think it's something that I would avoid in treatment in the absence of data to support its use.
And now Tiffany has raised her hand. So hold on just a second. Tiffany, let me allow you to talk. You can go ahead and unmute yourself.
Hi, Tiffany.
Hey, I follow you constantly. Love hearing all that you have to say.
God bless you. Thank you very much.
And I wanted to get in early, so I made sure I got my questions in. The next question I have is about crap gap. I've read a lot about crap gap. I'm newly diagnosed in March of this year, took my first Ocrevus in April, done well so far. So I haven't had any crap gap, but my question is, what I've been told is that DMTs do not help you get better. They only prevent further progression. So if they don't help you get better, then why would you have the crap gap? Does that make sense?
Yes. So we're talking about a class of medicines which deplete B cells. So the way that we think they work is you take them and then they make the B cells less populated, there's less B cells, and that way the B cells can't trigger the T cells to attack you. Those are B cell depleters. So these are like medicines like ocrelizumab, Ocrevus, Briumvi, Kesimpta, Rituxan. And there's a minority of patients that take these medicines that experience a seeming wearing off period where it would appear that the month leading up to their infusion, they just don't feel as good. Some of them just complain of related things to like fatigue, and sometimes they have like focal neurological things that come back. Immunologically, based on our understanding of the medicine, that's not supposed to happen, in quotes. Because when you look at the repletion of B cells, the B cells aren't coming back. So to your point, there's some neurologists say, "Nuh-uh, that's not true." But I don't think that thousands of people are all lying to me, telling me the same fib, right? I think it's probably real. And I just think that our scientific understanding doesn't allow for us to explain it away. What I would share with you is that most of my patients on B cell depleters do not have crap gap. They don't. And so I don't think you need to go looking for it, right? And I'll share that very commonly in clinic, when patients have crap gap, we have lotions and potions and maneuvers to help them navigate that. So I wouldn't go looking for it. And if it happens, then that's worthwhile talking to your neurologist about. So thank you for both of your questions.
Thank you. Ben is looking for collaboration or corroboration. He said earlier this year, at his last appointment with his MS neurologist, she mentioned that Ocrevus could possibly be going generic next year. Is there any truth to this?
So Ocrevus, is a biologic agent. So it's made in a laboratory, and it's a biologic product. It's not a small molecule. It's actually an antibody. You can't make generic antibodies. So there are no generic antibodies. You can make biosimilar monoclonal antibodies. So, for example, within the MS space, there's a medicine called natalizumab, and there's a trade name, Tysabri. That's a brand name of a form of natalizumab. Well, there's a different company that made a different brand called Taruco, right? And Taruco and Tysabri are both natalizumab. Because the Taruco is a biosimilar. Right now, there's a company called Amgen who is doing a clinical trial called the Oak trial. And in the Oak trial, they're enrolling patients with relapsing MS, and they're giving them either Ocrevus, ocrelizumab, or biosimilar Ocrevus. This is the very last test that needs to be done to satisfy the American FDA. When this clinical trial is completed, the goal of Amgen is to create a biosimilar ocrelizumab. If this were to seek fruition, we're not looking at any time in the near term. We're looking like years into the future. And generally speaking, biosimilars, which are used a lot in other fields, like in oncology, are very rare in MS. So it's partially true what she's saying, but I don't think that we're going to see any biosimilars in the next few years.
Thank you. Erin has a very lengthy question, so I'm going to try to summarize it. She asks, is it common for an MS neuro not to know what type of MS you have? And then she gives examples of what has been placed in her chart about the discussions of the types. She said that she's had a slow, steady decline over the years with cognition, spasticity, fatigue. She's still ambulatory, but everything has slowed down. And why are they hesitating labeling the type of MS?
So that's a complex question. So let's try to pick it apart a little bit. When you say MS neuro, to me, that means a fellowship-trained neuroimmunologist. So someone who completed neurology residency and then did extra years of training in MS like me. And so I'm assuming that's what you mean when you say MS neuro. And I would assume that any MS neuro who's been properly trained would know the differences of all the different phenotypes. Sometimes there are general neurologists who see a lot of MS patients, and they can be very competent, but they might not have that degree of formal education. So that's my first comment. The second comment is sometimes we don't want to give a diagnosis in the chart because it can have negative impacts from an insurance standpoint. So there's times in my career where if I wrote down that someone had secondary progressive MS, the insurance would say, therefore, I'm not going to give you a medicine. I'm going to deny you a medicine because the medicines are approved for relapsing MS. And I think as a result, you may see many, many MS centers that don't fully document those details for those reasons. There's a third possibility that sometimes a really intelligent, smart, observing neurologist might not want to weigh in yet. They may say, look, I'm not sure yet. I'm observing and watching the type of MS that you have. That stated, your desire to have a clarification of your phenotype is appropriate. And you should demand to have clarity about two things. One, prove to me I have MS is something that you should be able to say to your neurologist at any point in time, and they should be able to show you how they prove it's MS, and they should be able to tell you what kind of phenotype you have. And if you have a direct, frank conversation with your neurologist, say, hey, look, I really need you to lay it on me. And they're not picking up what you're putting down. Keep in mind that, we're helpers and that you might need to find a different helper who is more aligned with the way that you want to understand your disease.
Also, one of the things that Erin mentioned was that she has just been diagnosed after several years of symptoms.
Yeah.
So her neurologist hasn't had time to really watch the
And,
progression yet.
and
They did recommend Ocrevus because it's approved for both relapsing and primary progressive MS. Um,
which is so that's very relevant that they may say, look, I'm not sure yet. Here's what we're going to do. And we've picked a medicine that's going to stretch across all phenotypes. So no matter what it evolves into, we're copacetic.
Thank you. An anonymous attendee is asking, says that they're on the maximum dose of oxybutynin for urinary frequency and urgency. While it's helped, they're wondering if there are other medications that might help more. They're seeing their neuro next month and kind of wanted to get some information before going in.
So urological symptoms like bladder symptoms are extremely common in MS, right? We see it all the time. And oxybutynin is an old medicine which can help with overactive bladder. It relaxes the bladder to a normal carrying capacity size so that you can finish watching TV and then go empty your bladder, as opposed to having a near accident or accident. Oxybutynin doesn't respond, not every patient responds to oxybutynin, and there are many other anticholinergic drugs which one could use. I actually avoid oxybutynin as much as possible because of the side effect profile, because there's some data that would suggest that it could contribute to cog fog, to some dementia type symptoms in some patients. And since a lot of my patients are struggling with thinking and memory issues, I avoid oxybutynin. Two medicines that I like more are a medicine called Trospium or Sanctura, that's the same drug, and there's another drug called Myrbetriq. Now, Myrbetriq is my fave because Myrbetriq is actually not an anticholinergic at all. And so there's no similar side effects. Sometimes all of these medicines don't work adequately, and we're still having trouble with bladder. And I'm delighted that you're going to talk to your neurologist, because if that's in fact the case, it's reasonable to be referred to a urologist. So the neurologist will refer you to a urologist, and they have at their disposal many, many other tools that can help with bladder. They have procedures like bladder Botox. They have procedures like posterior tibial nerve stimulation. They have procedures like bladder stimulators, which can really help a whole bunch. So we do not ever have to settle for being wet or having a near accident. And I look forward to you talking to your neurologist about it.
Thank you. Sydney from Facebook says that they have started to have Lhermitte sign zapping down arms and into fingertips in May. The neurologist had her do another brain and cervical MRI, but there was no change from previous ones. Could there be a lesion that's so small that it's giving me the Lhermittes and also have an MRI not able to pick it up?
That's a great question. So here we have a clinical radiographic paradox. We have a human being who has a very clear neurological symptom that when she or he moves their head, they're getting electrocuted, right? And then we have an MRI that doesn't show anything. So one of the things that I think is really important to keep in mind in MS neurology is they do not have to agree, right? It's not as if we're not allowed to treat unless the MRI proves what the clinical picture looks like. That's BS. And in fact, when my patient has clear MS symptoms, I don't want an MRI. I don't need an MRI because the MRI is not relevant. The human's relevant. They're already telling me what's going on. Is it possible that you have a lesion which was missed on the MRI? Yes, that's possible. It's not as likely nowadays with the high field imaging that we use, but it is possible, particularly if the protocol doesn't have contiguous cuts. If there's gaps, they could skip and they could miss it. Also, you could have an old spot which is reactivated. But to me, that's a secondary conversation. That's like a nerd conversation. The real conversation is there's a human being, you, who is a you expert because you know more about you than the neurologist does, and you know more about you than the MRI does because you're you, like you're with you all the time, and you're telling me the answer. Hey, doc, when I do this, I get electrocuted. And so that's adequate enough, in my opinion, and in my clinic, that we would treat you for that, independent of what the MRI showed. because I don't treat MRIs, I treat humans.
Thank you. Teresa wants to know what new meds are out there for repairing myelin.
I don't have any new updates since the last Congress. So there's some hopeful work being done looking at a medicine called metformin, which is a medicine that was invented for type 2 diabetes. There's some hopeful information looking at a medicine called clemastine, which is like a second cousin to Benadryl. And there's a lot of ongoing trials right now, but I don't have anything new to add as of yet. It's my strong hope that at ECTRIMS here in the fall, we're going to get some updates.
Thank you. Tina wants to know what your thoughts are on the tau patch.
I would not spend money on the tau
Same
patch.
here.
I think it's quackery.
It is. Absolutely. An anonymous attendee has primary progressive MS with recurrent UTIs almost monthly. Last infusion, and since they're primary progressive, I would assume it's Ocrevus, was in July of 2024, last July. So it's been 12 months. Any hope of having another infusion?
So my first comment is I don't have enough information to really answer. Okay, so just to say that out loud. But taking it at face value, we might need to spend some hardcore energy controlling your bladder, right? So I'm talking about having a urologist on board. We may need to look at constant prophylactic antibiotics. We may need to look at Manos D to flush the bladder. We may need to look at doing some procedures. We've got to get the bladder so that you're not having recurrent UTIs. And the reason that's so darn important is because we don't have a lot of options to slow your disease down outside of this infusion. And so we want to be able to use it. I would get you to the urologist and don't settle until our bladder's clean to make it available for you then to benefit from the infusions.
The other thing that I might also add to that is that oftentimes repeated infections, particularly this frequently when you're on one of the B cell depleters, could be caused by a hypogammaglobulinemia. And unless that's been checked and corrected, once it's corrected, you may possibly be able to resume your infusions.
Although the concern here is she hasn't been treated in a year.
Yeah.
So one would hypothesize that if you had low IgG, it would have come back, and we're still having it anyways. I think your point is very valid, but I really think that we need to hone in on this bladder business.
Okay. Tina has her hand raised again, but wait a minute. No, Tina does. It's not Tiffany. I'm thinking it's Tiffany again. So Tina, let me see. I'm going to allow you to talk if you'll unmute, please.
Hi, can you hear me?
Yes,
We
ma'am.
can.
Hi, guys. I had two questions. I thought you were going to answer the one. How can you determine what type of MS that you have? That's the first question. And someone was asking about a medicine for remyelination. Dr. Gretchen, I'm sorry, Dr. Boster, I think you probably know who I know this lady, Dr. Gretchen Hawley. No?
Yeah, I know her really well. She's great.
Okay. Well, on her post, she mentioned a new medication called CNM-AU8, which is a nanocrystal solution. And it's been in study for 5.5 years. And it says in 2024, researchers confirmed that it shows progressive and actively the progression and actively repairs existing damage by remyelinating lesions that have been gone for years, have been there for years. And it also shows that it's improved vision, cognition, and mobility. And some patients have benefits that have lasted at least 3 years. So if you didn't know about that, maybe you could do some studying on that and let us know at a later date.
So that's very nice of you. So I'm very aware of that. And what you'll find in clinical research is timelines for development of drugs is weird. And so that's very encouraging, hopeful work, but it's not prime time yet. And
Okay.
that study will need to be published. It'll need to be vetted by peer review, and it'll need to be repeated before it becomes gospel. But
Okay.
yeah, no, I'm very, very aware of that, and thank you for bringing it up. The
Okay.
first comment is also very important. How do you know what kind of MS you have? I have several YouTube videos on this exact topic that you're more than welcome to check out. But just to speak to it for a few minutes, because I think it's a very relevant question, we sort out the kind of MS you have in the dumbest manner possible, which is basically a description. It's not very fancy. What we're looking at is if you are a human being with MS who has attacks or has had an attack, then we call that a relapsing form of MS. And if you're a human being with MS who's never had an attack, but has had a slow, steady decline in function for at least a year, well, then we call that primary progressive MS. And we're not making that distinction based on anything really on the MRI. We're not making that distinction based on anything in the spinal fluid. It's a phenotype or an outward description. And that's how it's done. I'll tell you a not secret. I think it's the same disease. And I think that there's different outward expressions. And I think I can prove that point. But for the sake of the discussion, the answer to your question is it's based on the way the patient describes their disease.
What about
Thank you.
secondary progressive? What about secondary progressive? I was diagnosed with secondary progressive MS. I had been having balance issues for some time. In 1996, my vision had kind of like gotten so bad that I couldn't drive to work. I was riding with someone and I was in the paint department. I had Googled, no one even mentioned MS to get it tested. But I Googled and they said some causes were direct exposure to chemicals. Where I worked at General Motors and I was in the paint shop. So I was right in the midst of it. When I got out of that department, like a month and a half, my vision came back and I had no issues with my vision. But I've always had balance issues. I thought I was because I had herniated and bulging disc, because I know if that pinches a nerve, that could affect your balance. But apparently, I don't think that was a primary issue.
So secondary progressive MS is a label that we give people who have MS, who have had at least one relapse, oftentimes have had relapses, and now they're starting to get worse in their MS without attacks. And again, it's done by description, and it can only be done retrospectively when we look back and say, well, geez, Louise, you haven't had attacks in X number of years, and you are progressing in your disability. And then we call that secondary progressive MS. Thank you for all your questions. I really appreciate it, Tina. Have a good rest of your evening.
Thank you. Irene from Facebook has primary progressive MS and is on Ocrevus. She started to see a hematologist this year and was told that she has a smoldering myeloma. How similar are the infusions for myeloma? She's being tested again this month and wonders if things are progressing.
I'm not able to answer your question.
Thank you. Karen from in the Q&A says she's 61, was diagnosed in March of this year, only spinal lesions, one brainstem lesion, no typical MS symptoms. Can this be MS?
Yes, it can be. Although there's a bunch of other things that can cause spinal cord symptoms and spinal cord spots. And so obviously we want to do a really thorough job of ruling out the other things.
Thank you. Another Zoom participant says, is there current or upcoming DMTs that stabilize the disease and can reverse, say, walking problems? Any that have the least amount of side effects?
Are there any current or upcoming DMTs that can stabilize the disease? Yes. Can any of them reverse, say, walking problems? Yes. Are there any that have the least amount of side effects? So many of the medicines that we currently have available, of which there's like 27 different current disease-modifying therapies, can help stabilize the disease in some patients. Some of these therapies are more likely to do it than others, but all of the therapies have a couple people at least who are super responders, where the disease-modifying therapy has worked really well for that human to stabilize the disease. And some of the newer medicines can boast about a 20 to 25% improvement in neurological status, where you can see a confirmed disability improvement. We call that CDI, which is really exciting. Now, side effects are, I need more than an hour conversation to talk about DMT side effects, but what I would submit to you is when you're looking at a drug, you're looking at the risk benefit. You're looking at the potential benefit to slow the disease down or stabilize the disease or maybe even get a little better. And you're balancing that against the risk of tolerability and the risk of side effects, right? And what I want you to do is I want you to put the risk benefit of the medicine inside the context of the risk of the disease. Because I think all too often we can really focus on side effects of medicines, which are possible, and we may ignore the fact that untreated or undertreated MS is a much worse condition to deal with. So that was a great question. Thank you for asking it.
I think also we need to not only balance the risk benefit, but realize that our MS side effects are often far worse than any side effects we can get from our medications.
Yeah, that's why I really think that putting the disease modifying therapy risk benefit in the context of the disease is such an important way of thinking.
Yeah. An anonymous attendee wants to know, when do we know that it's time to get help, like assisted living, home health, or a nursing home?
So in order to live on your own, you need to be able to do certain things. So you need to be able to obtain food and prepare food and eat food. You need to be able to get to the bathroom, use the facilities, and get off the toilet and back into your life. And when you start to have difficulties in doing those kind of things, you might need some help. So we call this the activities of daily living, like putting on clothes and obtaining food and eating food and toileting and showering and stuff like that. And if you're having increasing difficulty with those things, it may be appropriate to start to think about getting assistance. Now, sometimes the assistance is making modifications to your house. So, for example, you may have difficulty getting in and out of a tub, but you could wheel into a shower, right, and use a shower chair. For example, you might get a food service which prepares meals that you can then heat up. So sometimes you can make adaptations, and occupational therapists are very good at doing that and helping you with that. Sometimes we need to get help in the home, and sometimes there's all we need is someone who comes in the morning for an hour or two, or comes in the bookends of the day to help us get ready and then get in bed. Sometimes that's not enough, and sometimes we need to be in a facility which can provide those services for us. But those are really all focused around your ability to get your activities of daily living done.
Thank you. Tricia was on Betaseron for 30 years, went off of it in August of 2024, and she's only on Zepbound now for her A1C. And she's wondering if she could go back onto an MS med, and if so, can you suggest a medicine that will give the least side effects? She had none on Betaseron except for being a pin cushion.
So the first question is, can you go back on a drug? And the answer is absolutely 100% yes. And I think you should. Like, I would strongly encourage you to do that. Since you were on Betaseron, there's been so many new drugs that are developed that will blow your mind. And I guarantee you, even without meeting you, that I could find something that you could tolerate. And the reason I guarantee that is not because I'm magic and I know a lot about you, because I don't know you. It's because there's 28 different drugs and they all have different side effect profiles. And so we will be able to find something that you can tolerate. And very likely it's not going to be a shot.
Thank you. Jane says, can you tell me if certain eating habits or foods can help with MS, since I'm not on any meds right now? I was diagnosed 2.5 years ago at the age of 58, and I've had bad reactions with drugs for MS. Please tell me if there's anything you can recommend for me to do or someone to see for help.
Yeah. So when I'm trying to help someone make their MS boring, there's 5 things I want them to do, right? One of them is to exercise as part of their lifestyle. One of them is to not smoke stuff. One of them is daily mindfulness. And then there's 2 more. So the fourth one is to eat smart. And the fifth one is to take the most effective disease-modifying therapy and make sure that it's working. So eating matters. And I hate it when doctors say dumb stuff like what you eat doesn't matter, because it does matter. And if you get into this topic of diets and MS, you can learn a lot about different diets that have been proposed by various doctor types over the years. There's a bunch of different ones out there. And there's ongoing rigorous debates about this one's better, and things like that. I've looked at all these diets, and the theme is food quality. So avoiding ultra processed foods, sugar-laden foods, fried foods, fast foods, diet foods, eating single ingredient foods, which any child could pronounce, like a chicken, apple, broccoli, like those are real foods, is a really, really great way of living your life with MS. Now, we can get very fancy pants about a discussion of diet, but honestly, if you spent your energy and your resources and money buying whole foods, you'd be in a such better position than most of people in the United States. Now, that stated, I want you to consider taking a medicine, right? Because diet by itself can't do it adequately. And so I hear you that you've had bad side effects from medicines, but you haven't been on every medicine. And as far as who to talk to, I want you to find a neurologist that is willing to work with you and to try to help you navigate through to find something that you can tolerate. Best of luck.
Thank you. Linda has her hand up. Linda, I'm going to ask you to unmute and ask your question. Linda? Okay, let's take the next question in queue while Linda is queuing up.
I got it.
Oh, you got it. Okay, Linda, go ahead.
Okay. So I've been on estrogen replacement therapy for years. I'm 63 years old. This spring, I tried to go off, and it just made my fatigue much, much worse. So I went back on, but I'm still fatigued. How important is estrogen to MS?
So estrogen is a really interesting hormone. And it turns out that when women with MS have fluctuations in their hormone levels, that they can have an uptick of MS symptoms.
Mm-hmm.
So it's really interesting. We can see that even with a monthly menstrual cycle. In the setting of menopause or perimenopause, I think estrogen has recently come into light as being really important. And
Okay.
I actually recommend that my patients talk with their obstetrician gynecologists about estrogen-only topical hormone replacement therapy.
Okay.
Now, that stated, there's lots of other things that can contribute to fatigue and MS.
Mm-hmm.
Like many, 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 like I could come up with like 60. And so in addition to addressing your hormone replacement, which I think is a really good idea, there's a host of other things that we would want to look at.
Okay. Thank you.
Very much. Thank you.
Thank you, Linda.
Mhm.
An anonymous attendee is physically active and does their best to continue to be despite subtle but persistent MS symptoms. How do you recommend balancing intense physical activity with long-term disease management? And is there a point where pushing through symptoms could be doing more harm than good, even without relapses?
So you can't make your MS physically worse through exercise. If you exercise a bunch and overdo it, get overheated, what have you, you can have a temporary time when old symptoms come back out, where in the setting of being overheated or exhausted, you can have a reemergence of old symptoms. But once your body cools back down, that'll all go away. And so the trick with exercise is really pacing and slowly building up your functional reserves. And when I say slowly, I mean like super slowly. And so two metrics that I find to be very helpful when trying to game out exercise is if you exercise and 2 hours later, you're still a wreck, then that was too much. So if you do a hard workout and your legs are kind of wobbly for an hour or two, that's acceptable. But if 3 hours later you can't go up the steps to go and home, then you overdid it. The second tool is the way that the second day goes. So if you have an exercise on Monday and you have the best exercise ever and you do all the things and you're very excited, and Tuesday you're in bed, you overdid it on Monday. And so I would use those two feedback tools to help you guide out your exercise.
Thank you. We have 26 questions still in the Q&A, and we've got 25 minutes left on our time. So I'm asking that people not raise their hands for now, that we need to burn through these questions that are in the Q&A. Erica from Facebook is asking, is there an age that you suggest for stopping or changing medication? And I will say, Erica, that next Tuesday, Dr. Thrower is going to be addressing that topic specifically at 4:30 p.m. Eastern Time. So I'll be putting information out on Facebook about that. But Dr. Boster, did you want to add anything more to that?
Yes, I always stop medicine at death. I refuse to treat someone for MS after death. I don't do that, and I've never done it my entire career, like over 20 years now. Pre-death, as long as you have neurological features that you're fond of, like seeing, smelling, hearing, wiggling your finger, then I want to do something to protect that nervous function against your immune system. So I treat until death, but I never, ever, ever treat after death.
You, sir. An anonymous attendee asks, what's up with the bariatric chamber for help with MS?
So I don't know what's up with the bariatric chamber. It was all the rage to do hyperbaric oxygen, and I've never really seen that bear fruit. There are some centers around the world that have hyperbaric chambers, and there may be patients that feel like they benefit from it, but I haven't seen compelling data, which makes me want to ask patients to go do that. And so I might not be the best neurologist to ask about it.
Thank you. Vera has been on Ocrevus since 2019, but is having some side effects with that. She wants to know if the new subcutaneous Ocrevus has similar side effects.
So the manufacturer of Ocrevus reformulated their product, and so it can now be given through an IV the way we've been doing it, and it can be given subcutaneously, which means under the skin. And it's got a bit of a different side effect profile. So it's the same medicine, it's administered slightly differently. And I haven't noticed massive differences in the side effect profile long term, one versus the other.
Thank you. Karen said she believes that loss of hearing in her right ear was her first MS symptom, which resolved with oral steroids. Have you heard of this as an MS symptom, and would MRIs prove that that was an MS symptom?
Yes, I've heard of that as an MS symptom, and it's possible that you could see it on the MRI, but not guaranteed.
Anonymous attendee is asking for the significance of a very low reading for neurofilament light change for a long-term MSer with a lot of prior brain lesions and black holes on MS-DMTs for over 2 decades.
So neurofilament light chain is a way of measuring brain health. And so if you have, let me find, so if you have an axon, which is like the wire part of the neuron, and it breaks for any reason, all the stuff inside leaks out. And inside are these chains, neurofilament heavy, medium, and light chain. And the neurofilament light chain, if it goes up in the spinal fluid or up in the blood, that means there's been more damage in the brain. And so a high number is bad and would suggest that whatever disease you're looking at is maybe more active or worse, and a low number is considered good. and would suggest less disease activity. Now, we don't use neurofilament light chain as gospel by itself, but it's increasingly becoming a useful biomarker which can be ordered in the bloodstream.
Thank you. Sarah is one of your YouTube followers. She has a question about MS risk management in kids of patients affected by MS. Nine years ago, she was found to have the HLA gene that predisposes to MS, and it's activated by EBV. The daughter has the same gene, and a couple of years ago got EBV. Immediately experienced optic neuritis, had an MRI that seemed fine, but now ChatGPT told me that there are lesions that are not visible. She is 13. Sarah wants to know what she should do.
Okay. So well, first of all, hi, Sarah. So as I understand, mom has MS, daughters had mono, and daughter had optic neuritis, is the way I interpret that. So if we think about the daughter, this is a person with a first degree relative with MS who has had a clinically isolated syndrome. In that person, independent of age, I'm monitoring with MRIs frequently for at least 5 years. And I might be doing other tests to try to clarify the risk profile of going on to develop MS. What do I do in the meantime? We want to make sure that the person does not smoke, because smoking would double their risk to develop MS. So that would obviously be like a no-no. We want to make sure that she has supplemented her vitamin D. And I try to get the vitamin D 25OH level to be above 50, but below 100. That's the range that I want it in, which is associated with less risk to develop MS. I would avoid morbid obesity and inactivity because that also increases the risk to develop MS. There's a little tiny literature that suggests that ultra-processed foods may increase the risk to develop MS. And so those are the things that I would do. I would live my life. I would take vitamin D. I would get my MRIs. I would report symptoms that I had, and I would stay very physically active.
Thank you. Jenny's having a lot of dizziness and vertigo, often in the morning, but also sometimes when she's at the computer and while driving. Could this be MS related, i.e. via nystagmus?
So MS can cause vertigo. So when a human says the word dizzy, I try to put it in one of three boxes. Vertigo is the hallucination of spinning, right? And that's one of the three ways that someone might be dizzy. And vertigo is a very common phenomenon in adult humans, and it's a very common phenomenon with MS. So it could be related to MS.
Thank you. Jane is not taking any MS meds right now because she's JCV positive, and she can't take certain meds and she's worried.
So the JC virus is a virus which over half of 30-year-olds and up have, right? So that's very common. And when you look at MS medicines, there's probably one medicine, maybe two, that I would avoid if I was a high JC virus antibody positive patient, which means there's about 26 medicines that you could take. So get ye back to the neurologist and say, what else can I take? Because that's not the only option that's available.
Thank you. Alyssa's head has been hurting since last week. It feels like something is pinching hard and then releases, and in a few minutes it starts all over again. What can I do to get relief?
So I can't diagnose or treat you on the interwebs, and you need to see your doctor so that we can do a proper workup and try to figure that out.
Karen says, follow up. I had no symptoms, only now I have funky eyes and double vision, right leg weakness, and no other typical symptoms. So that's just a follow up to a previous question. Christine says, I have neuropathy in both feet, which causes pain at night. Is there anything I can do to relieve the pain and stiffness? I work out and go to a physical therapist.
So there's several things that we can do. And again, I'm not recommending you do any of these things without talking to your neurologist, of course. Stretching before bed is very, very helpful. I would stretch out the calves, the hamstrings, the quadriceps, the hips, the butt, the back, and I would hold each position for a minimum of 30 seconds. I would do a couple repetitions. And this will cut down on spasms quite a bit. You want to make sure that you're adequately hydrated because spasticity and neuropathic pain will be worse if you're dehydrated. You want to make sure that your room doesn't get too cold because spasticity can be worse if it's really, really cold in the room. There's a host of things that we can take, both natural supplements and pills, prescriptions, that can help with this. So, for example, some of my patients that have bad spasticity, they'll take magnesium before bed, which is an over-the-counter. There's also a lot of medicines that one can use, things like um, uh, membrane stabilizers, like seizure medicines, like you've heard of Lyrica and you've heard of gabapentin, Neurontin. There's a host, maybe 10, 15 medicines that one could use to help manage neuropathic pain. Even cannabis can help with neuropathic pain and spasticity and facilitate sleep. So the point is, there's a host of things that we can do, and getting your snooze on is super, super important. Because if you're up all night with spasticity and neuropathic pain, you're kind of cutting your legs off before you start your next day.
Thank you. Stephanie has an interesting tweak on her cog fog that she's experiencing it. She has it more frequently in random moments while awake and also while asleep. What is the best way to handle the situation?
Having cog fog more frequently in random moments as I'm awake and as I sleep. So bluntly, I don't know how you have cog fog while sleeping, because typically while you're sleeping, you're not like doing like any cognitive communication stuff. So I don't fully understand that. What I will say is that cog fog is super common in MS. I would say upwards of 70% of people have some cog fog. I've got innumerate YouTube videos on how I like to manage cog fog, and there's a host of things that you can do. So I would present to your neurologist, say, hey, this is a problem I have, and I want you to knock it out.
Also, might want to get a sleep study done, because if you're waking or semi-waking with that kind of confusion, it may be due to a sleep disorder. Nicole says, what are your thoughts about MS being linked to GERD and IBS?
True, not related. So GERD is very common, IBS is very common, MS is very common, but I don't know that one causes the other. I see them in patients all the time together because they're very common conditions.
An anonymous attendee is asking a very lengthy question, but basically, is there any way you can tell how long you've had MS over the years with so many lesions and hypointensities, and the symptoms started in 2013?
The real answer is no. Um, the best that we have is really two pieces of information. Your story, like when did it start, right? So we can at least identify symptom onset. And also, sometimes when you look at the MRI, particularly early on, like the first MRI, it can give you a sense that the disease has been there for quite some time. But we're not really awesome at being able to pinpoint that.
Thank you. An anonymous attendee says, thoughts on the percentage of people that are helped with walking speed while on Ampera, side effects, and how long before you know it's working?
So the package insert would say about a third of patients respond. And I would say it's about right, about a third to half of patients respond. I would also submit to you that it takes about 2 months of being on it to clarify if it works or not. So if you're going to take it, I would take it for at least 60 days before I decided whether or not it was working.
Says, I'm a 64-year-old male with primary progressive MS that affects my right leg only. I'm not taking any MS medications. There are no new lesions on the MRI for the last 9 years, but my walking ability is getting worse. The neurologist chalks this off to smoldering inflammation. What is your take on this? And thank you for holding this session. It's very informative.
Hey, Chris, you're quite welcome, and thanks for being here with us. Primary progressive MS is a situation where you slowly get worse over time, and you are slowly getting worse over time. And the medicines that have been FDA approved, or the medicine that's been FDA approved for PPMS, slows that down by about 24%. So my opinion is your disease is behaving the way that one would expect it to, not on treatment, and I would get on treatment to try to slow that down.
Marietta says, I've been on Tysabri for 9 years with no relapses, approaching Medicare age. Will Medicare cover my Tysabri and will I have to pay 20% because I can't?
So Medicare will cover any drug almost, but they'll only pay 80%. And so my strong opinion is if we're going to stay on Tysabri, you need to purchase secondary insurance. So you can go to the marketplace and you can buy secondary insurance, which will cover that 20%. And that can make it affordable.
Thank you. Sabrina says, I was diagnosed last November and started Kesimpta in December. I only have brain lesions, no spine. My neurologist ordered a yearly MRI for this December, but only ordered the brain MRI and not the spine. Is this normal to just get a brain MRI?
Yes. So the Consortium of MS Centers recommends that you do an annual brain, and they don't recommend doing a spine unless you have symptoms attributable to the spinal cord. That stated, I like to get a spinal cord every couple years because every once in a while you can see asymptomatic spots that pop up. But it's not abnormal not to get a spine every year.
Maria says, howdy, when do you know it's time to change your DMD?
That's Marla. Hey, Marla, it's really good to
Oh,
see you.
Marla, I'm sorry.
So I keep someone on their disease modifying therapy unless one of 5 factors occurs. They have an attack on their therapy, they have new spots on their therapy, their exam gets worse on the therapy is no longer safe, or the therapy is no longer tolerated. If one of those 5 things happen, then I hit pause and then we talk about we might feel it's necessary to change therapies.
Okay, an anonymous attendee is newly diagnosed last month. The neurologist is recommending Vumerity as a disease-modifying therapy and said that if he does, or if they do, their MS will not get worse. To me, after waiting for a couple of years, who will take me seriously? This seems too good to be true. Am I just being cynical? Could this actually work? What is your take on Vumerity?
Vumerity is a mid-range drug as far as efficacy is concerned in groups of people. Meaning, if we take a group of people on Vumerity and a group of people on another medicine, Vumerity is sort of like middle of the road. I don't think it's adequate in its efficacy personally for me to use in my practice. In an individual human being, you either respond or you don't respond. And you could start Vumerity, and it is possible that you could be a super responder to it and have no disease activity. If you start Vumerity, I would proceed with a 0 tolerance policy for breakthrough disease. And the second that I had a new spot or an attack or failed the litmus test of life, I would immediately upgrade because there are medicines out there that are more efficacious than that drug.
Thank you. Krista says, I've been taking Ocrevus since 2018 for relapsing remitting MS. I've had mild cognitive decline, Lhermitte's, balance gait, all causing anxiety. I'm now having joint pain, referred out to rheumatology and orthopedic. I get up and good to bed with discomfort. I feel put off by my MS specialist. No change in MRI, so I'm feeling the specialist isn't even considering these issues are related to MS.
So I'm going to infer that the question is, what do I do about the situation? And I would start by having a heart-to-heart with your neurologist. You and your neurologist have an intimate relationship, right? It's an intimate relationship because the two of you are trying to game out how to help you live your best life despite having MS. And so I think it's fair to say, hey, neurologist, I don't feel like I'm being heard. These are really bothersome symptoms. Is there anything that you can do in addition to help? And then you have to kind of have a conversation. They may say, hey, look, it's outside my purview. I sent you to the rheumatologist. But I think that the way that you navigate that is you start with an open and honest conversation. If you're not comfortable, because some people may not be comfortable coming to the neurologist with that concern, I would write it down on a piece of paper so that you can hand it to the neurologist. Another tool is I would bring a village member with you when you have that conversation, just so you can have a support system in the room with you while you talk through that.
Thank you. Angie says, the cardiologist told me I have POTS. Is there a connection with MS and POTS?
No.
Another anonymous attendee wants to know how much vitamin D and calcium do people with MS need daily?
It depends on what your levels are. And so I check blood levels, and then I can answer that question. I would submit that in the Midwestern United States, where we don't have a lot of sun for half the year, I oftentimes find myself putting people on 5,000 international units of D3 a day. But I'm not telling you to take 5,000 international units. I'm just sharing what I typically find my patients take here in Ohio.
Okay, we have an anonymous attendee that is also asking an oxybutynin question. They want to know if there's something that can be taken with it to help it to work better.
No.
Stephanie says, is modafinil good for cog-fog?
Yes, very.
Anonymous attendee says, I take only baclofen when I have debilitating pain, but I avoid taking it daily. Would it be better to take it regularly for spasticity, or is it an as-needed use okay?
You can do both. It really depends on how often you're having spasticity and when during the day. So I have some patients that only take it as needed. Some patients only take it at night. Some patients take it 4 times a day. And really, it kind of depends on your degree of spasticity and your situation to help us guide what we do.
Thank you. Laura from Facebook is asking, is there any link between autoimmune angioedema and MS?
No.
Karen from Facebook asks, what medication can I take for muscle uncontrolled movement?
It depends on what kind of uncontrolled muscle movement you're talking about, because there's several different kinds of uncontrolled muscle movements. What I would do is I would film it. So I'm like, let's pretend that your hand is doing some weird movement. I would literally film it with your smartphone and bring it to your neurologist so they can watch it and try to help figure out which kind of abnormal movement it is. And that's going to help us clarify what kind of therapy we need to use.
So Marla is saying, do I take magnesium before bed for spasticity?
So magnesium can help with spasticity whenever you take it. I have a lot of patients that will take magnesium either before bed or twice a day to help with their spasticity.
Thank you. And it looks like we have ticked them all off. Thank you so much, Dr. Boster, for your help with this. For those of you who want more of Dr. Boster, he has his own YouTube channel, which has both lengthy and bite-sized clips that are very, very helpful on symptom management and disease management. Please go visit him. Also, this webinar and all of the webinars by the MS Foundation or MS Focus are on our YouTube channel as well. So when you go to YouTube, just look for Dr. Boster or the Multiple Sclerosis Foundation, and we've got lots to help you. Our next feature is Tuesday, the 12th at 4:30 p.m. Eastern Time. And Dr. Thrower will talk to us about will I ever be able to stop my MS therapy or when to stop MS therapy. You've got Dr. Boster's take on it. My take is very, very similar, that we have things to treat just about any stage of MS that you've got. And so we'll look forward to what Dr. Thrower has to say about that. If you're on Zoom, please stay on the line for just a moment after this webinar ends. You'll be getting a short survey your answers hopefully will help us to serve you better with topics of which you have interest. Thank you so much. Have a wonderful rest of your summer and good night.
Good night, everyone. Thank you again.